right, so in the interest of time, let's go ahead and get started. Thank you everyone so much for joining us today. We are very excited to have you all here for the first session of our 3-series workshop on congenital syphilis. My name is Talia Parker. I'm the manager of program operations at the National Coalition of STD Directors, or NCS. Whoops, I was muted. How much did you miss? A couple of housekeeping notes before we get started today. So as you can all tell, we are in a Zoom meeting and not a Zoom webinar. We chose this intentionally so that we can allow for the connections and collaboration that we are looking for, particularly in the next 2 sessions, where we will have some opportunities for action planning and breakout rooms. But in the meantime, that does create a few limitations on our session here. So I'm going to ask everybody, please be respectful, make sure that you're staying on mute unless an opportunity comes at the end to raise your hand and ask a question and take yourself off of mute. We can use the chat for questions and also to connect with each other. So as the presentation is going, if you come up with questions, feel free to put them in the chat and we'll collect them for the end of the session. This session is recorded and it will be distributed on NCSD's website and through our listserv, so you'll be getting it after the fact. And then finally, we will be putting a brief evaluation in the chat at the end of the presentation to gauge interest in future webinars as well. So without further ado, I'm going to go ahead and introduce Dr. McDonald. Dr. Bobby McDonald is an internal medicine and pediatrics trained physician on the case-based surveillance team of CDC's Division of STD Prevention, or DSTDP. His areas of focus include adult and congenital syphilis, as well as the global emergence of antimicrobial resistant gonorrhea. Prior to joining DSTDP, he was a CDC Epidemic Intelligence Service Officer field assignee at the New York State Department of Health. Thank you so much for being here today, Dr. McDonald.
Great, thank you for having me. And one other thing I'll share too, just about my background, because it's relevant to today's talk, is that outside of my day job in the division, I also provide clinical care, mainly STI, HIV, and harm reduction care in here in Atlanta. So thank you all for having me here. And then I'd also just like, if people could in their in another window or on their phone, if you could go ahead and pull up this website, and there will be a question on there that is, what is the biggest barrier to stopping congenital syphilis in your jurisdiction? And we'll kind of create a word cloud that we can go back to later in the conversation. So kind of an overview of what I'd like to do today is talk about a little bit about why we care, why syphilis, why now, talk about congenital syphilis and female syphilis trends, talk about some of the efforts that DSTDP is doing around congenital syphilis, and then discuss barriers to addressing congenital syphilis. Before we get into some of the details of the data, I want to touch base on a couple key points about CS, just to make sure that we're all speaking the same language today. So CS, or congenital syphilis, is an infection acquired in utero with T. pallidum, the bacteria that causes syphilis. Transmission is transplacental when a pregnant person has untreated or inadequately treated syphilis. There can be a lot of serious consequences, including miscarriage, stillbirth, premature birth, and infant death. At birth, a child with early congenital syphilis can show no signs of infection, or they can have signs such as hepatosplenomegaly or problems with the liver and spleen, rash, snuffles or copious nasal discharge. They can also have condylomata, jaundice, pseudoparalysis, anemia, edema. And then if the people are not noticed or they're not identified early in life, later presentations can happen if CS is not diagnosed until later or over 2 years old. And so it can present as complications with the eyes, such as classic presentation here, shown here, of interstitial keratitis, or deafness can occur. There can be complications in the mouth, such as Hutchinson teeth shown, or mulberry molars, or holes in the hard palate. Other complications in the skull can happen, such as frontal bossing and saddle nose, as seen here in this bottom right picture. And skeletal findings can happen too, which can eventually present as the classic saber shins shown here at the bottom. So there are other less common complications as well, all fairly severe, and again, all something that can be prevented. For testing, the STD treatment guidelines put out by CDC last year recommend testing any fetal death after 20 weeks gestation. This should be tested for syphilis. Pregnant patients during the first trimester or their first prenatal healthcare encounter should be tested. Retested should again happen at 28 weeks and at delivery if an individual lives in a community with high rates of syphilis. And that's, I think, an important caveat, because I think often that's something that's missed by providers. They're looking more at individual risk factors instead of the community risk factors that exist. And finally, they recommend that no mother or neonate should leave the hospital without maternal serologic status documented at least once during pregnancy for syphilis. The 2021 treatment guidelines recommend treating pregnant persons per their stage of infection. And so any treatments spaced greater than 9 days during pregnancy are considered not acceptable, and the series should be restarted. And finally, inadequate treatment is likely if it occurs within 30 days prior to delivery. So again, they have to be treated 30 days before delivery. The surveillance and clinical case definitions are not the same. And so a clinician may choose to treat an infant with CS, even if they do not meet the surveillance definition or criteria for CS. The case classification decision for surveillance, that belongs with the health department and not with the diagnosing provider. According to the Council on State and Territory Epidemiologists, there are 2 different classifications of congenital syphilis: probable and confirmed. To be classified as a confirmed case of congenital syphilis, which is quite rare as far as identifying and reporting as a confirmed case, an infant must have the bacteria isolated and directly identified. With probable congenital syphilis, there are infants who meet the criteria and they warrant treatment based on their mother status. When a person presents for delivery and has a history of untreated or inadequately treated syphilis for the stage of infection, the infant can be classified as a case of congenital syphilis. Additionally, some infants may be classified as congenital syphilis cases, even if their mothers are adequately treated. So this requires that an infant that have a reactive non-treponemal test and symptoms of congenital syphilis. So there's a variety of ways that an individual can be classified as congenital syphilis. So it's also important to touch base on CSDE's case definition for syphilitic stillbirths. These are when fetal deaths occur after a 20-week gestation or when the fetus weighs greater than 500 grams and the mother has had untreated or inadequately treated syphilis at delivery. Let me move this off your screen. So adequate treatment is defined as adequate treatment is going to be when someone has completed penicillin-based regimen in accordance with the treatment guidelines discussed earlier and appropriate further stage of infection. And again, that's happened 30 days prior to delivery of the stillbirth. So I think this one is important because it always throws me for a loop because it's based on the maternal criteria and it's independent of any potential laboratory findings in the fetus. So now to kind of go into the trends of congenital syphilis and just taking a minute to note, if anything important comes in the chat, just please interrupt me because I can't see the chat while presenting. So in the US, all of these main reportable STIs continue to increase. Syphilis is increasing, but the pace of congenital syphilis is more prominent and increasing faster than that case with syphilis. I was asked to kind of paint a picture for the national crisis around congenital syphilis. And as all of you here on the call today know, congenital syphilis is no longer an isolated issue. In 2010, only 29 states and the District of Columbia reported one or more cases of CS. In 2019, 43 states and DC reported one or more cases. This trend has continued, and almost all states have been impacted by CS in some way. To see why we're seeing these trends in CS, we need to look back a step at the adult syphilis trends. In the early 2000s, men who have sex with men, or MSM, made up the majority of primary and secondary syphilis cases in the US. But as you can see on this slide, over the past several years, we've been having a level off of the numbers of cases among MSM. Unfortunately, though, we continue to see an increase among women of reproductive age, along with men who have sex with women only. In 2019, half of all counties reported syphilis among women of reproductive age, and there was a doubling of this over the decade. In 2010, only 27% of US counties reported at least one case of syphilis at any stage among women of reproductive age. This trend is not so surprising, again, taking that step back and looking at the increases of syphilis in general. We were approaching syphilis elimination in the 90s, but we continue since then to see increases in syphilis. In 2019, there were nearly 130,000 cases of syphilis, and that represents a 13% increase in the number of cases compared to the year prior. During 2010 to 2019, the rate of total syphilis increased 167%. Early non-primary, non-secondary syphilis increased 189%, and primary and secondary syphilis increased 107%. Rate increases vary by region of the country. I'll focus on primary and secondary syphilis because that's the most infectious period of the disease, and therefore it's driving the epidemic. For PNS syphilis in 2019, they were the highest in the West with 16.9 per 100,000 population. And that also is a 13.5% increase compared to 2018. I've also included this map here with the rates of states so that folks on the call can have a better idea of their individual states and their surrounding areas. And it's always something that can be referenced back in the discussions later. Although we're seeing syphilis and congenital syphilis are impacting more counties, in 2019, 45 or about 1.5% of all the counties that were reporting their data here accounted for half of all reported cases of primary and secondary syphilis. So again, we're seeing syphilis disperse across the country, but there are still concentrated pockets with a higher rate burden of congenital syphilis and primary and secondary syphilis. Looking more specifically at PNS syphilis among women, increases among all age groups continue to increase with rates highest among women in their 20s. And per the data in the US, the mean age for pregnancy in the US is mid-20s, so that matches well with the rates here. Not only is syphilis among women diffusing to previously unaffected areas, rates are also increasing in areas that have a history of syphilis among women. For example, if we look at all stages of syphilis among women aged 15 to 44, and look at percentages of states reporting a rate greater than 20 cases per 100,000 women aged 15 to 44, we see that in 2010, only 6 states and the District of Columbia, that accounts for 14% of the reporting areas, reported a rate greater than 20 per 100,000. But by 2019, that increased to 30 states in DC, which is about 61% of reporting areas. So in that decade, the percentage of states reporting a total syphilis rates for women aged 15 to 44, those that reported greater than 20 per 100,000 jumped from 14% to 61%. So that's a significant dispersal across the country. So now taking a little bit of a turn and moving back to congenital syphilis, the rates of congenital syphilis here they are for the individual states. Those mirror the rates of PNS syphilis seen among women, which again is not too surprising. Nationally, the numbers of congenital syphilis case reports reported, they continue to increase. In an effort to expedite data release around congenital syphilis, the division released preliminary data for 2020 in July of last year. And based on the data at the time, we projected 2,100 cases. 2020 data are still being finalized with delays in reporting secondary to COVID. But based on the preliminary review, we're going to surpass that number. Additionally, in this data, 47 states and the District of Columbia reported at least one case of congenital syphilis in 2020. And of those states with prior reporting of congenital syphilis, 32 states and the District of Columbia reported case increases relative to 2019. So cases are dispersing across the country, and where cases were previously seen, we're seeing more. Of the 2022 infants included in the 2020 preliminary data, 139 were reported as stillbirths or infant deaths. And congenital syphilis related deaths continue to increase and consistently represent 7% or about 7% of all reported CS cases. So although the US is not the only country facing increasing rates of congenital syphilis, I know it's happening in Canada, UK, Australia, there are a growing number of countries successfully addressing congenital syphilis. And among those countries, they're also achieving WHO elimination status for maternal to child transmission. There are additional steps to achieve this status, so it's not just based on case rates. But I think it's important to kind of see where we fit in a national or international framework. In the US, in the early 2000s, again, we were doing well. Then the rates of congenital syphilis were about 8 to 12 cases per 100,000. But then in the last few years, we've seen that steep increase in the rate. And if we use the 2020 projected number of 2,100 cases, the congenital syphilis rate in the United States will be 56 cases per 100,000 live births. So we will have exceeded the WHO's elimination of maternal to child transmission goals for syphilis. And while the national rate of CS is projected to exceed the goal in 2020, in 2019, 9 states exceeded the elimination of maternal to child transmission goals set by the WHO. One final thing about the 2020 data, as I'm sure many of you have been doing, we're continuing to evaluate the effects of COVID-19 on STI numbers. To see the impact of COVID-19 for 2020 data, Melissa Pagoa and others put out this paper last year comparing the weekly numbers for reported PNS syphilis cases in 2020 to those that were reported in 2019. There were more weekly cases in 2020 in the first 2 months. Then there saw a deficit or a drop during March and April with those initial COVID-19 shelter-in-place orders that went out. And in the fall, the weekly number of cases in 2020 began to uniformly surpass the numbers reported weekly in 2019. So the reasons for the declines in reported cases are likely multifaceted, including reduced screening and possibly changes of incidence depending on movement of populations. But the declines in early 2020 were seen in gonorrhea and chlamydia during that initial period as well. So it's less to be thought less about the individual disease than about effects of lockdown. So moving into a little bit of discussion about data around disparities. We continue to see disparities on who is most impacted by congenital syphilis. Rates of reported congenital syphilis cases increased for all race Hispanic ethnicity groups during the 2015 to 2019 period. And you likely will have noted the increase of 1,348% among American Indians and Alaska Native persons. That jumped from 10.7 to 154.9 or 155 cases per 100,000 live births. This figure here is another way to look at the disparities in the preliminary 2020 data, and it overlays the case numbers on the rates, but the disparities in high burden of cases can also be noted. So rates are now highest among American Indians and Alaska Native persons at 180 per 100,000 live births as just discussed, but there's a high burden of cases among the Black or African American persons, with 693 cases and a rate of 125 per 100,000 live births. The rate increases and disparities seen in congenital syphilis, again, generally mirror rate trends and disparities seen in primary and secondary syphilis. So although there is an increase in rates among AIAN and Native Hawaiian persons, are not as prominent here as they are in congenital syphilis. That would be the one main difference. Broken down by race and sex among males, Black males have the highest rate at 53.5, and among females, AIAN females have the highest rate at 15.4 per 100,000. When comparing rate ratios by sex, race, and region, the rates of reported primary and secondary syphilis cases among American Indian and Alaska Native, Black, Hispanic, and Native Hawaiian or other Pacific Islander persons were higher than the rate among white persons in 2019. Similar disparities were seen in all groups and in all regions of the United States. So moving to talk a little bit about interventions. In the division here, we hope to build on the successful interventions to control congenital syphilis. So to help kind of achieve this, we've been working to identify points at which it's best to intervene, such as those identified through analyzing missed opportunities for congenital syphilis prevention. During 2015 to 2019, the majority of missed prevention opportunities among mothers of infants with congenital syphilis happened here in these two top categories. As you can see in 2018, no adequate maternal treatment, despite recipient of timely syphilis diagnosis, overtook the timely prenatal care and testing. So at this point in the CS crisis, we really should not be seeing an increase of individuals not receiving adequate treatment if they're pregnant and diagnosed with syphilis. A challenge with congenital syphilis and syphilis in general in the US is the geographic variations. And so in examining missed opportunities to prevent CS, each region of the US was unique. In the South, the most common missed opportunity was a lack of adequate maternal treatment. While in the West, the most common was a lack of prenatal care. However, the principal missed opportunity in all states was not preventing syphilis among women before they became pregnant or while they were pregnant. So now to kind of address some of the efforts that are being done to address CS in the division. In 2020, we saw the first STI National Strategic Plan being put into place. And that actually came out of HHS, so it was a larger federal effort. And the plan focuses on the 5 goals you see listed here: preventing new STIs, improving the health of people by reducing adverse outcomes of STIs, accelerating progress in STI research, technology, and innovation, reducing STI-related health disparities and inequities, achieving integrated, coordinated efforts that address the STI epidemic. And so this was something that was put out, again, by the national government, and it involved many divisions outside of just Health and Human Services, including things such as housing or the Department of Housing at the federal level. And throughout all of this, syphilis, congenital syphilis, and disparities are pivotal parts of the plan. And overall, it's pretty exciting to see this kind of level of interest from higher levels in the federal government. One key area for controlling syphilis has been case investigation and contact tracing of partners through disease intervention specialists, or DIS. And with the American Rescue Plan Act for direct relief of challenges from COVID, funds have been provided for DIS workforce development. And so the goals here are expanding and enhancing frontline public health staff, conducting DIS workforce training and skills building, building organizational capacity for outbreak response, evaluating and improving recruitment, training, and outbreak response. And of this is $1.13 billion was allocated for this DIS development. And so for the next 5 years, $200 million will go to the state and local health departments for DIS activities. 50 million will go towards innovation in the field, such as diagnostic development for syphilis. And the last 50 million will go towards training of DIS. Outside of personnel development with DIS, we're also working towards innovation in the lab. And so one thing that's being worked on is STI diagnostic development and working on direct detection tests for T. pallidum in samples of genital ulcers and adapting the RPR syphilis test to novel formats. We're evaluating 2 dual point of care tests for the screening of HIV and syphilis. And kind of in partnership, we're working with NIH. There's a syphilis specimen repository that's in development there. And we're also working on enhancing surveillance of T. pallidum strains. In an effort to help combat rises in congenital syphilis, the division is making efforts to really report out national data earlier and disseminate it as broadly as possible. As an example, last year, preliminary CS data was released early onto our website. And then in conjunction, in an effort to better reach medical providers and policymakers, the data were released early and accompanied by a report in the New England Journal of Medicine. And that was also accompanied by a post in Health Affairs, which is one of the main journals used by health policymakers. Around the same time, the division also reported out about congenital syphilis in the neonatal period in pediatrics, which is a main journal that reaches pediatricians. So really trying to get a broad array of approaches towards clinicians as well as policymakers. Additionally, from the perspective of surveillance, the division provides technical assistance to jurisdictions in case identification and reporting, and that has been happening remotely as well as in person during outbreak response. We partnered with CSTE to develop a series of webinars related to syphilis and congenital syphilis case definition and hosted a series of small group trainings as well. And I also here want to just take a moment to plug our team's new email address for everyone, just with people potentially moving teams or being deployed for COVID or for other field responses. We wanted to create a email address that could be used to reach whoever was in the office as fast as possible. So for any of your surveillance questions, you can CC this in your email, and hopefully we'll get you an answer faster. And then outside of the assistance provided by the surveillance team, there are other teams in the division providing technical assistance both remotely and on the ground, including various EpiAids that have been going on. From a programmatic and policy lens, we're working on some new activities for congenital syphilis. And some of those activities include developing a strategic plan for the division. And this plan is outlining activities for CDC and local health departments to help implement interventions to help prevent and control congenital syphilis. We're also enhancing our data and surveillance to identify the impact of emerging health threats to pregnant people and their infants. We're evaluating cost effectiveness of syphilis screening and looking at prenatal screening laws for syphilis. And we're partnering with state and local health departments to build out on the portfolio of possible congenital syphilis interventions. So that includes finding the best ways to test people most likely to have syphilis, such as strengthening partner services, or to screen people with higher than average risk for syphilis, such as jails or emergency room screenings. And through that, finding better ways of treating people quickly once they test positive. And so of all the various projects mentioned, I do want to highlight this one, as it's a project I'm involved with and excited about the potential findings. So in 2020, the US Congress recognized the increase of congenital syphilis and provided CDC with funding to be distributed to states to address CS prevention. So through this mechanism, CDC is funding 4 states to develop, implement, and evaluate interventions to reduce CS in the pre-birth stages of congenital syphilis. So really specifically targeting females of reproductive age and pregnant individuals. The program is currently funded at $1.5 million per year, and that will continue based on future budgets that were provided. So with the funding, recipients will work to influence one or more of the critical opportunities for congenital syphilis prevention during or before pregnancy, such as increasing use of prenatal care, more timely and targeted syphilis testing, and/or appropriate syphilis treatment upon syphilis diagnosis. And so some of these interventions that are being evaluated include implementing screening and treatment for women of reproductive age in areas where their local epidemiology indicate women are going to be at the highest risk. And these potentially include corrections facilities such as jails, syringe service programs, and programs for substance abuse, and other community programs. Although some women might not have prenatal care, data indicate that they often do seek care at some point during pregnancy. And this may be their only time that they actually contact healthcare. And so for this, the idea is some of these interventions will put programs into place to automate syphilis screening for pregnant patients presenting to emergency departments. Another state identified a rural community with a high burden of congenital syphilis, and they found that individuals there were experiencing homelessness and/or substance abuse. So to address this, the state has partnered to create an open access prenatal care clinic to decrease barriers to accessing prenatal care. Another state is working to improve its partnerships, referrals, and reaching out to provide care and services directly to women who are at greatest risk for syphilis. So we're looking forward to seeing the outcomes of these interventions, and I'm happy to hear from any of the partners who may be on this call here today. So moving into a discussion to talk a little bit more about the challenges that we face in addressing congenital syphilis. We've discussed the geographic variations for syphilis, and we also need, though, to recognize that it also goes beyond that and that there's nuances in policy for syphilis prevention and control. Most states have established prenatal syphilis screening laws as of 2021, but there's still a great variation among the regions and states in the US. So currently, most states just have prenatal screening requirements for their first prenatal visit. But there's variations from state to state, as well as different screening recommendations from various organizations. And this can often cause confusion among providers. And talking about barriers to successfully preventing CS, and just, again, I'll caveat to say that any opinions that I give would be my own opinion and not that of CDC, but to quickly revisit some of the data seen earlier, I'm often pretty frustrated that people are not more moved to action when they see these data around disparities. If we don't address the disparities of who is most impacted, we will not see success in addressing congenital syphilis. Another barrier is access to care, which is a major issue in preventing people from obtaining proper prenatal care. And there can be many causes for this, and that includes a lack of access to healthcare or potentially a fear of accessing care. And this may be because of concerns about getting child protective services or other legal issues when they go to seek medical care, or it may be because of concerns around immigration status as well. And I'm sure many of you guys have heard these same stories, but I had a pregnant patient with syphilis in clinic last year who missed her third appointment to get treatment. But to get into our clinic, she had to have a friend drive her to catch a bus. And then that bus took her to the MARTA subway stop, which is not the best rail system in the country. And then when she got to the train station downtown, she then had to get an Uber from the MARTA station to clinic. So all of this was while pregnant during a pandemic. And so I personally would certainly miss my appointment if I had to go through all of that. And I think it's pretty impressive that she was able to make it on time for the first two appointments. Luckily for us, we were able to schedule her using some grant money to hire a car to bring her into clinic the next day to get her some timely treatment. But if these barriers and access to care are not addressed, we will not have success in addressing congenital syphilis. And with these barriers, it's also important that pregnant patients are tested for syphilis the first time that they're seen in the healthcare infrastructure. So even it may not be an official prenatal visit, anytime they show up, whether it's to get care during an emergency room visit or some sort of other access to care, it's important to test and treat them at that time. Additionally, there are various ongoing syndemics contributing to syphilis and congenital syphilis. So I want to pause for a moment to review some of the data around drug-related behaviors in syphilis. So in looking at self-reported drug-related behaviors among women with primary and secondary syphilis, you will see continued increases. So most significantly, the proportion of persons with BNS syphilis who report meth use increased to 22% in 2019. So that means 1 in 5 women with syphilis report meth use. Among all people reported with primary and secondary syphilis, women self-report more injection drug use than others. Women are consistently higher than other groups, and this is not a reflection of necessarily who is getting interviewed, as the number are calculated among those who are interviewed. Like we've seen in other data, there are regional variations. So these reports of injection drug use differ by US region for women with primary and secondary syphilis. The proportion reporting injection drug use is highest in the West, but there have been substantial increases in the Midwest and South in recent years. We see similar trends by sex and sex of sex partners when we're looking at methamphetamine use. Among all people who reported primary and secondary syphilis, women self-reported more methamphetamine use than others. And similarly, reports of methamphetamine use differ by US region for women with primary and secondary syphilis, with the proportion highest in the West, but again, increasing in recent years in the South as well. So tied into this is the education and resources needed for clinicians to help provide proper care for women with syphilis, so that, an important thing again is just for clinicians to be aware of the rising incidence in their own community and the potential risk that their patients have, or even to think about knowing to test. And as it's been highlighted by the COVID pandemic, the data infrastructure in the US is fragmented, which adds delays in reporting and analysis of data. So this leads to deficiencies and delays in interventions and in response to clusters and outbreaks of syphilis and congenital syphilis. And finally, there are many competing priorities in public health. Also kind of included in this is the fear of some in addressing sexual health. But added to this is the historic defunding and downsizing of STD programs. Traditional methods of syphilis control are struggling to keep pace with the current morbidity that's seen. And so, as seen in the reporting of rates of disease intervention here on the slide, those have declined while reported cases have increased. So it's important to mention some of the bureaucratic barriers as well that happen when funds come through government systems. So even though funding may be received, funding may expire before all the bureaucratic hurdles are completed and people are able to hire and implement programs. And that's happening at the federal, state, and local levels, as well as the fact that qualified individuals may not be available to fill jobs or to fill jobs at the salaries that are offered. So want to take a moment to see if people want to go to this website here, and then they can go ahead. Oh, I didn't give people a second I may not have activated that previously, but if people want to take a second to write about the biggest barriers that they see to stopping congenital syphilis in their jurisdictions. And while people are doing that, I will also just share for those that are interested our references and resources. And I can also open it up if there's any questions as well while people are doing this. And I have a few other questions that I want to pose to the group, but while that's happening. If there's any questions, I'm happy to take them.
Thank you so much, Dr. McDonald. I'll go ahead and read a few questions while we wait. Why does a dose have to be started over after 9 days?
Yeah, based on studies that have been done looking at successful treatment of a pregnant person who has syphilis, it's found that that's kind of the optimal amount of period of time where they have to have a certain level of the penicillin in the body to successfully go transplacentally and treat the fetus as well. So that's kind of where that 9-day limit is. And if they get beyond those 9 days, kind of the peak of the level of penicillin in the body drops down and it's not as successful at treating the fetus. And so the fetus is at higher risk. And with that, we've also seen even people who are getting treated appropriately, seeing cases of people who are not, who are still having breakthrough cases of syphilis.
Thank you. And is there any new data about a syphilis vaccine?
So I think the idea would be that a vaccine would still be years away. So even though there's some research and efforts into that, it's not in the near future.
And is there any data on a breakdown on why after diagnosis there is no treatment?
So you're saying about for the people when a pregnant person is diagnosed with syphilis, why they don't get proper treatment, is that correct?
I believe that's what the question is getting at.
Yeah, I think that some of that, for some of the data, we don't have too many details, but some of it is, again, looking regionally where we see the differences in different regions, and that would just be either quality, or access to care that people are having or proper follow-up. I don't know if others on the phone have any additional information that they want to provide about that data, but it's really in kind of the follow-up and the care provided. One of the things that we've seen is that often the patients that we have that would be someone who would be at highest risk for congenital syphilis often are considered high risk, or they don't show up to their clinic, and then they end up getting discharged from the clinic or sent elsewhere. And then this kind of loses their history of treatment or diagnosis. And so someone who drops in and out of care has more difficulty getting kind of the complete care.
Thank you. And somebody is wondering if beyond the supplemental funding recently awarded to STD control programs for COVID-19, if there are any mentions of increasing base funding for STD control programs to sustain current efforts to prevent congenital primary and secondary syphilis.
Yeah, I mean, I personally would love more funding. As far as the exact funding that comes, that's all a decision that comes from Congress. And so I, as a federal employee, can't advocate that Congress gives more money to STDs, but as a clinician in the community, I would like to see more money going towards that. But I think if from within the division too, there will be an update coming to the PEACH grant, which is the main mechanism for dissemination of funds to the states that will be coming in the near future that could potentially address some of these, freeing states up more to address congenital syphilis.
Thank you. Maybe we can take a break from questions and go back to this word cloud, see what people have shared, if that works.
Yes, definitely. So thank you guys all for sharing that. I know it's helpful for us to see, and I think it's also helpful for you guys as you move forward in these conversations here. And again, it looks similar: access to care, testing, education providers, prenatal. So they all seem very, very similar. I also want to take a moment here. Kind of another question that I had was for people to rank the following barriers from most significant to least significant for your jurisdiction. So hopefully that is activated. and people can go ahead and rank for their jurisdiction as well there. And while that's happening, if there's other questions, I'm happy to take any of those.
Yeah, there's a few more. Somebody asked, could you talk more about the enhanced interest in syphilis recently? Is this a major difference from previous years in treatment and surveillance funding and attention?
Yeah, I think the reason that we're seeing an increase of interest in syphilis and congenital syphilis, one is from the idea that just from congenital syphilis, we should be at zero. In a country with the finances and medical care that we have and access to medicines, these numbers should really be at zero. It should not be something that's happening in the US. And so I think it's very concerning to see children being born with congenital syphilis in the US at this time in history. And so that's a real reason to focus on congenital syphilis and those significant outcomes that can happen. As well as with an attention on syphilis, again, was that we had some success in moving towards elimination previously. And now to see these numbers going up, it's become concerning, and to try to really address it. And we're also seeing it move to different populations as well. And so as we see it jumping populations, we also want to kind of alert people, and it's now going to end up being, new communities, new clinicians. And so making sure that everyone is as aware of possible as the problem is spreading to try to prevent it as much as possible.
Thank you. And somebody else asked, will there be amendments to the National STI Strategic Plan given the increased issues with access to timely prenatal care and treatment?
Yeah, so a lot of that is included in the plan already. So it does actually incorporate a lot about access to care and inequities around care.
Great. And one final question, then we can go back to the word cloud. Are you aware of any updates on the application for FDA CLIA waiver for the dual rapid syphilis HIV test by ChemBio? Would be a huge help for testing in the field.
So I think the last update we know of was in December. The FDA requested additional data from the company, so it's still under review, but agree that the increasing access to rapid tests would be very helpful. So just taking a moment to look at how people have voted on this. So you guys collectively have ranked disparities as being the highest, and then clinical education care, and access to care, syndemics, competing priorities, and then data modernization and timeliness. So I have two questions here that want to get to. So one, since we don't just having this opportunity to kind of meet with people, want to know from your perspective, what's the most important thing CDC should do to address congenital syphilis? And then after that would be, in your opinion, what could CDC do to make it easier for your jurisdictions to address congenital syphilis? So if people could take a moment to answer that first question, and then we can go to the second one as well. Are there any other questions that people have? And people can also feel free to share your opinions on these two things or on any of the things that we've discussed as well today.
Yeah, and also while we're waiting, if people want to in the chat, say what maybe resonated most with your experience from this presentation. I'd love to hear people's thoughts on that while we wait.
And also, while we're painting these, I'd also love to hear from folks what they have found as being successful interventions that they've had in their own jurisdictions that may be beneficial for others to hear about.
And I also just want to remind folks that this is the first of our series, so we will be getting further into the weeds on some of these issues in the next 2 weeks. But I think this is a really great conversation to begin today. So I'll just read some of the chat responses. Somebody said provider education and working with labs to more clearly offer and get providers to order complete testing. National recommendations for syphilis screening in emergency department and urgent care settings, provide housing for people without housing, more public service announcements, increase education and testing, and increase in staff, a national syphilis or congenital syphilis awareness campaign, more funding for data modernization and surveillance, awareness campaigns, eliminating bureaucratic barriers, access to funds, alternative treatments, perinatal case managers. Thank you, everyone. These are all fantastic. Legislation, more focus on congenital syphilis and other syndemic diseases. Somebody has asked in the chat, they said disproportionate morbidity among Indigenous populations is really upsetting. What is the situation with tribal health funding for maternal child health, STIs, and HIV?
Yeah, and I would agree. It's very upsetting to see that. And I currently, a lot of the funding that goes to tribal populations comes through states. So a lot of the money is allocated from the federal government to the states, and then from the states, it's then the idea would be that it's then allocated to the tribal populations. And so in some jurisdictions, that would be sharing a certain portion of the money with the jurisdictions, with the tribal jurisdictions themselves, or it would be the state or county or local jurisdiction implementing policies or implementing programs to address the rising rates. We also partner with the epicenters, and then we also partner with Indian Health Service as well, where we can.
Great. And did you want to show that final word cloud, or is that just for your own benefit?
Yeah, I will share with what we have here. And also it's more of, I can scroll through them. And I guess I just open it up to in the last couple minutes that exist, if anyone has any other questions or comments as well.
Also, if anybody would like to come off of mute and ask a question, you are more than welcome to. I'm going to keep reading some of the chat because it's very interesting. Recommendations for repeating STI screening during third trimester of pregnancy, lack of staff assigned to congenital syphilis, having providers attend continuing education around congenital syphilis, field tests and treatment, being able to give BIC in the field. Any home syphilis testing kits? Does anyone have any final questions for Dr. McDonald before we wrap up for today? If not, I do want to run a quick poll of our own to gauge response to this session today. And then I'm also going to drop a full evaluation in the chat for folks to give more feedback if you have it. Thank you so much, Dr. McDonald. I want to remind everybody again, we have 2 more sessions. So our next one is on January 25th. And there we will be covering surveillance, case review, and data-driven approaches to congenital syphilis. So we'll have presenters from Texas and New York City speak to some of their programs. And then on February 2nd, we'll be covering innovative testing and treatment programs. And we'll be hearing from Los Angeles and Louisiana, as well as Diagnostics Direct about their rapid syphilis test. So a lot more information coming your way. And as I mentioned at the beginning of this session, the next 2 sessions will be more interactive. We'll have breakout sessions at the end of presentations. And we really want to be able to, I see some people have asked questions of other programs as well in the chat. So we will have opportunities to try and address those questions further on as well.
Great, and thanks again for allowing me to be here. And I have here my email and then the surveillance team email that I mentioned. So happy to always answer any questions that anyone has or join people for kind of a conversation or a brainstorming session as well.
Great, thank you so much. We'll end a few minutes early here. That was super efficient, but we gathered a lot of information. I'm really excited to continue these conversations into the next few weeks. So thank you again, Dr. McDonald, and we hope to see you all again next week.